And is Dr. B.P. Manjula. She is a professor in the JSS Medical College. She is a recognized PG guide since 2004, and she had fellowship in interventional pain management and palliative care. She is executive committee member of ISA, and incidentally, she is the organizing co-chairperson of this conference. And her area of interest is pediatric and pain medicine. She has 12 publications in various journals. Dr. Manjula, please.
Good morning, everyone. This is the hospital. This is a hospital where I work, and I want to take a welcoming you all, delegates and faculties, to this conference on behalf of our organizing committee. Thank you. So today's topic is lung protective ventilation during anesthesia or in operation theatre. Is it really necessary? So what is this perioperative protective ventilation? Is pre-oxygenation is a valid tool, and how to protect the lung? That means what to do, why we should do it, and how we can do it, and what do we need for it. So post-operative pulmonary complications during major open abdominal surgery or laparoscopic surgery or cardiac surgery or thoracic surgery like etc. are common due, it may cause volutrauma, barotrauma and electroma and oxygen toxicity. It affects post-pulmonary outcome and general outcome of the patient. And factors like positioning, pneumoperitoneum, circuit disconnection may lead to the basal atelectasis, which results in the reduction in functional residual capacity and overstress of the lung, and which increases in driving pressure, which invariably causes post-pulmonary complications. So this is the pathology, like how injury can occur, like a high tidal volume or a high plateau pressure, or with a low tidal volume with no PEEP or alveolar de-recruitment can occur, can lead to epithelial and endothelial damage, which increases the alveolar capillary permeability, which releases the systemic release of inflammatory mediators, which causes biotrauma and which affects the systemic organ dysfunction. And other causes also, like already told, major surgeries, excessive blood loss, excessive fluid loss, sepsis or blood transfusion can lead to injury. So what are the guidelines on intraoperative ventilation? Usually followed is FiO2 should be titrated to produce normal arterial oxygen level and saturation, and prolonged periods of high FiO2 can result in hyperoxia. It should be usually avoided. These are all the post-pulmonary complications occur. The main cause is pulmonary edema, and there is also anesthesia related, which causes around 8% of which leads to post-pulmonary complication. So re-intubation within the first 3 post-operative days is highly associated with the increased risk for in-hospital death. Approximately around 5 to 8% of patients undergo general surgery will develop pulmonary complication. One of the 5 patients who develop pulmonary complication will die within the 30 days of surgery. The number of pulmonary complication is strongly associated with the post-operative length of stay, which leads to short-term or long-term mortality in the hospital. So anesthesia is at least seen usually in children under the age of 6 years, and also patient under the 30 years, obese patient and pregnant women in the last trimester, and laparoscopic surgery, and anesthesia in Tenderberg positioning also makes lot of difference, and thoracic and cardiac abdominal surgeries. So effect of ventilative parameters on outcome. there is always discussion like whether protective really needs or not. So, protective versus conventional ventilation, why we should go for a protective ventilation? There should be reduction of major pulmonary and extrapulmonary complication from 27.5% to the 10.5%. And there will be a reduction in NIV or intubation for acute respiratory failure from 17% to 5%, and reduction in hospital stay, it reduced to 2.45 days. So, the appearance of post-pulmonary complications was lower in patient receiving protective ventilation compared with a patient receiving conventional ventilation. This was published during 2015 with a study. So, how we can do it? The protective ventilation using the low FiO2 and with a low tidal volume, and using the PEEP and applying the recruitment maneuvers, and also using the inhalation anesthetics and low flow anesthesia. There are the few pictures showing that face mask NIV with pressure support of 8 to around 10 centimeter of water and with a PEEP of 6 centimeter of water improves pre-oxygenation in obese patient. Before intubation we can use, and this shows pre-oxygenation with NIV before intubation, and another is apneic oxygenation. So, how you do the protective ventilation in operation theatre? In standard ventilation we use tidal volume of around 10 to 12 and without no PEEP and no recruitment maneuvers. In protective ventilation, using of tidal volume of around 6 to 8 ml per kg with a predicted blood body weight, and PEEP of around 6 to 8 centimeter of water with the recruitments repeated every 30 minutes after tracheal intubation. So, what we know about the PEEP? This PEEP does not recruit itself. It collapses or re-expansion occurs during the tidal volume. The increases in FRC hence increases the surface and allows better oxygenation. In alveoli will not have to repeatedly construct surfactant in monolayer and improves the compliance. And recruitment of previously collapsed lung with a re-recruitment maneuver. PEEP may avoid collapse and de-recruitment in a lung previously expanded recruitment, and also it reduces the atelectrauma. What is the recruitment maneuver? It is an alveolar recruitment maneuver is the reopening of the lung tissue collapsed by increased airway inspiratory pressure. And recruitment breath is sustained, increases in airway pressure with a goal to open collapsed alveoli, and after which sufficient PEEP is applied to keep the lungs open during mechanical ventilation. And it also refers to the opening of collapsed alveoli, de-recruitment to the collapse of open alveoli. So, what are the types of ventilation you can use? There is no exact one ventilation type of ventilation you can use. CPAP with increased pressures, pressure control ventilation on high PEEP, advanced recruitment maneuver, prone ventilation to recruit dorsal lung unit, high frequency oscillatory ventilation, and airway pressure release ventilation with a low PEEP and low tidal volume with a IE ratio of 4:1. What are the recruitment maneuvers you can use? The types are sustained inflation, PCV with high PEEP and PCV with increase in the PEEP with a psi. What is the use of it? It increases the oxygenation, it decreases the shunt and increases the pulmonary compliance. It works better in ARDS, early ARDS. There is no uniform way of performing this recruitment maneuver, and it may reduce postoperative atelectasis, and it generally safe to use. It does not harm the patient, and important is to set PEEP to prevent alveolar collapse post-recruitment maneuver. So, how you do the recruitment maneuver? Use pressure control ventilation, set respiratory rate to the 0 and turn off the apneic alarm, and increase the PEEP gradually from 25 to 40 centimeter of water in 40 seconds. Like example, begins with PEEP of 25 and is carried out in pressure control with a driving pressure of around 15 centimeter of water. Most recruitment can occur in the first 10 seconds with a hemodynamic compromise occurring later. What is driving pressure and how it is related to post-pulmonary complication? It is the difference between the plateau pressure and the level of the PEEP. The driving pressure was only significant mediator of the effect of protective ventilation on development of post-pulmonary complication. There was a study which shows the p-value of 0.027. Higher driving pressure can indicate poor lung condition with a decreased lung compliance or stiff chest wall, which is the predicted the development of post-pulmonary complication. Reduction in driving pressure was significantly related with a reduced incidence of pulmonary complication. This is where picture shows the principles of lung and diaphragm with a protective ventilation of driving pressure with changes in airway and pressure. Intraoperative low tidal volume ventilation in conjunction with PEEP and intermittent recruitment maneuver is associated with significantly improved clinical pulmonary outcomes and reduction in length of hospital stay in otherwise healthy patients. So, consider these application of all three elements for a comprehensive protective ventilation strategies. So, can we really apply the same ventilation to every patient? There are so many studies done about the protective ventilation, whether it works in the operation theatre or not. So, few studies like which anesthesia regimen is best to reduce morbidity and mortality in lung surgery, a multi-center randomized study. And other one is high versus low positive end expiratory pressure during general anesthesia for open abdominal surgeries, and association between the driving pressure and development of post-pulmonary complications in patient undergoing mechanical ventilation for general anesthesia. And also when we are talking about inhalation anesthetics, effect of volatiles and intravenous anesthesia on the alveolar and systemic inflammatory response in thoracic surgical patient. The outcome was showing increased alveolar concentration of the pro-inflammatory mediators, and also volatiles can suppress local alveolar but not the systemic inflammatory response. And also another study was meta-analysis of intraoperative ventilation strategies to prevent pulmonary complication. Is low tidal volume alone is sufficient to protect the healthy lungs. So, after all these studies and research, they come to some conclusion of using the tidal volume of 6 to 8 ml per kg of ideal body weight, which avoids valve trauma, and recruitment maneuver which avoids the atelic trauma and opens the lung. It can be done if required, but hemodynamics has to be monitored carefully. Use of NIV before intubation can be considered, and PEEP of 6 to 8 centimeter of water using this can avoid atelic trauma, keep the lung open, and low plateau pressure of around 17 centimeter of water can avoid barrel trauma. Low driving pressure, that is less than 13 centimeter of water. In recent anesthesia practices, especially post-COVID, we can't always guarantee or sure that every lung is normal, even though patient is with a ASA 1 or 2. So, using of this protective ventilation can avoid especially basal atelectasis, which can lead to the early ARDS in post-operative as a post-operative complication. Thank you.